Bipin, you can carry on.
Yeah, so carpometacarpal dislocations. So I'm covering carpometacarpal dislocations other than the thumb. So these are less than 1% of hand and wrist injuries, and they occur with other associated fractures. So these are the most of the dislocations are missed on X-rays of the wrist and hand due to overlapping of the bones. So with anatomy, you will realize that there is a volar carpometacarpal ligament. Dorsal carpometacarpal ligament is the strongest. There is an interosseous ligament. So in the motion, when you check the motion of your own hand, you'll see that the fourth and the fifth CMC joints are the most mobile, and they are the most forgiving ones. Like whatever you do, the fourth and the fifth metacarpal joints are the most mobile ones. Second and third are very fixed joint. So any injury to the first and second and third metacarpal joints cause significant disability, whereas injuries to the fourth and the fifth metacarpal joint, though they are the patient is able to make fist, but there is persistent pain, and it doesn't cause a very significant disability. So the type of joints here, these are the same. The fourth and fifth are saddle type of joint, whereas second and third are plain type of joint structures, and they are relatively rigid. So what you will look at the radiograph. So these are very subtle dislocations. Patients complain of pain, swelling, and injury, mostly a bike accident or a fall on a hand. So always look for the CMC carpometacarpal clear space. So this is very obvious here. If there is a fracture dislocation, or if there is a fracture dislocation of the CMC joint, this clear space won't be there. You have to look for this space. Another important thing is a metacarpal head tangential line. So always draw a line along the tangential of the third, fourth, fifth. The most commonly missed one is the fifth one, because you will see that for those who don't look at hand X-rays very often, we'll see that everything is normal, like I will show you in the next X-ray here. So if you see here, so another view which is important is a lateral view. You have to draw a line along the third metacarpal dorsal part and see that it does that all the metacarpals are aligned well here, and the 30-degree pronated oblique view. Now what I said here is there is a dislocation here of the fifth carpometacarpal joint. You can see that there is obviously that the fifth metacarpal has come down. Now that what you draw here is a tangential line, you will appreciate that the metacarpophalangeal joint is proximal, and it is subluxated proximally. So this is a dislocation here. So always remember that it can be only a dislocation, or there can be a small flake here, as you see here. In this case, there is a small flake here. So this is a fracture dislocation here. So here again there is a fifth carpometacarpal dislocation. The tangential line drawn, the metacarpophalangeal joint is not aligned. So what happens that fix it, because of these deforming forces. So and you need to reduce it and fix it or stabilize it basically. So there is on the fifth metacarpal ECU and the abductor, so you need to fix it. So what do you plan for is close reduction or ulnar gutter slab. So if it is stable, ulnar gutter slab is good enough. Or if it is unstable, then put a K-wire if it is unstable. Open reduction internal fixation also might be required in very late or old cases. So this is a case in which the fifth CMC joint is reduced and stabilized in an ulnar gutter cast. Remember that the metacarpophalangeal joint, the cast should not cover the metacarpophalangeal joint, and you ask the patient to move the metacarpophalangeal joint. So this is another second metacarpal base fracture with subluxation of the third metacarpal. So in this case, you need now as I said in my initial some slides, that the second and the third the carpometacarpal joint are the rigid and the most unforgiving ones. So you need to fix this rigidly. So what we did is we fixed the first first metacarpal with a plate, and the second metacarpal with the plate, and the third metacarpal just fell in place. So we did not have to really fix it. At 1 year of follow-up, you see that the patient has a fairly good amount of movement, and he is able to make good fist here. Always remember that when you're approaching on the radial side or on the ulnar side, you have to take care of this the radial cutaneous now on the radial side. So this is the most important structure, and the tendons, of course, but the radial cutaneous nerve causes a lot of deficit if this is injured during this procedure. So these are very high energy traumas, and there can be an impeding compartment syndrome like in this case. So as in this case, you can see that the third, fourth, and fifth carpometacarpal joint, there is a dorsal subluxation. You need not have to see the Shenton's line here. And the joint is misaligned. Everyone will recognize there is a carpometacarpal dislocation. So the main aim is to align the third metacarpal on the capitate. So always look for the third metacarpal and align it on the capitate. Fasciotomy is also important. So when you approach this when you open this injuries, fasciotomy is obviously done, and you have to fix it on the third metacarpal. So always align it on the capitate, third metacarpal on the capitate. At 5 years, the patient has a fairly good amount of movement with good fist and grip. Now this is a divergent type of injury. You can see that all the metacarpals are divergent on one side. These are very, very, very high energy trauma injuries with compartment syndrome. So as I said, fasciotomy is must in these cases. Open reduction and fixation with multiple K-wires was performed. And after 3 years, the patient has fairly good amount of movement. Though the patient complains that there is some problem here and there, but that doesn't really cause his functional deficit. So the take-home message is that the fourth and fifth carpometacarpal joints are relatively common injuries, and they are very mobile joints, and they can be reduced with closed means. Second and third carpometacarpal fracture dislocation need a relatively high trauma. They can be associated with carpal injuries and compartment syndrome. Don't hesitate to do a fasciotomy. Stable fixation with K-wires or a plate can be performed. Beware of tendons and cutaneous nerves. Late injuries need reduction, stenolysis, and aggressive therapy. Thank you. Yeah.